When we have collapsed discs, there are a few different things that can cause pain. We can obviously have pain from the disc itself, which is, called discogenic pain. We can have pain from the nerve roots that get compressed because when the disc collapses, the ligamentum flavum usually collapses and hypertrophies with it, which then pushes on the central nerve roots. And then obviously if you're in the cervical and thoracic region, that can push on the spinal cord, or it can close off the little foramen, which are the holes where the nerve roots exit, and can cause, symptoms down the leg. It can also cause facet mediated pain, which we're gonna rightfully assume that you have that because your radiofrequency ablations to the facet joints have been overly helpful for you. And so you also have some facet mediated pain. So when I approach cases like yours, where we are trying to avoid surgery, sometimes the way I think about these things is, how can I give this patient an additional 5 years? Because maybe in 5 years, things will be dramatically different with fusions, and maybe they're actually a little bit smarter at that. You know what I mean? So I also try to be realistic in that sense on, hey, you may need, depending on the severity, you may need a fusion at some point, but can we push this off by 5, 10, 15 years? So that way, because you're still young, right? That way we can, let science catch up a little bit and medicine catch up, and maybe at that time there are much better options. So the way that I will generally approach this is evaluating with obviously physical exam, evaluating those different structures. We evaluate the discs, we evaluate the nerves in the area, we evaluate the facet joints. We look at the other supporting ligaments that help provide some of the curvature to the spine, so the interspinous ligaments, the supraspinous ligaments. We look at the multifidi muscles, all of these things that are important for a structurally sound spine. Then we look at that and say, okay, what do we think is off? What do we think is dysfunctional? What do we think is contributing to pain? And then we look at treating those things. In the regen space, the closer someone is to needing surgery, the stronger the therapy generally needs to be. And so that's where we're looking at doing either a bone marrow concentrate procedure, an adipose stem cell procedure, a combination of both of those procedures. Sometimes we'll recommend adding in a placental matrix product because that has extracellular matrix and some growth factors and things like that in it. Those are the easy questions to answer in terms of what do we inject. The bigger question is figuring out what exact structures are in need of help and repair, so that way we can create a meaningful impact on your pain, so that way you can continue to live life and prolong the need for surgery until either a point where there's amazing stem cell procedures that are covered by insurance where they can heal discs, in 10 years, or surgery is actually a smart option in 10 years because of advancements in medicine, things like that.